Alright, today we're going to go over Fundamentals Exam 3 study guide. Let's knock this bad boy out. Alright, let's talk about ways to prevent aspiration risk. Don't use straws. Use thickeners to slow the progression of the fluid over the palate. Liquids are easier to aspirate than solids. Watch for pocketing. Sit up and stay sitting for 30 minutes after your meal. Stop feeding if dysphagia or pocketing occurs before oral hygiene. Alright, what's the route of the GI tract? Mouth, esophagus, stomach, duodenum, jejunum, ileum, cecum, ascending colon, transverse colon, descending colon, sigma colon, rectum, anus. What are the causes of diarrhea? Stress, virus or bacteria, antibiotics. What are the risks of diarrhea? Dehydration can cause metabolic acidosis because you can lose bicarb. How to treat diarrhea? Treat persisting cause and restore normal peristalsis, IV, and stool softeners. You can do a Bristol stool scale too. Alright, how do we treat constipation? Laxatives, cathartics, enema, and digital removal of stool. Start with least invasive method. What are enemas? Go into rectum, sigma colon to stimulate peristalsis. Alright, what's a tap water enema? Volume distends the bowel, riskier because it's hypotonic and cause water intoxication if it stays in the gut. Use caution repeating it. What is a normal saline enema? Isotonic, considered the safest enema. What is a hypertonic solution enema? It's a fleet enema, pulls solution out of the interstitial space. What is a soap sud enema? Castile soap creates intestinal irritation to stimulate peristalsis. What is an oil retention enema? Dried out stool absorbs oil so it's soft and you can pass it. What is a carminative enema? Gets gas out, think car. Medicated enema is that one that we know about. Alright, can we delegate enemas? Yes, you can as long as it's not a med. What is positioning for enemas? Left lateral sims, not while on the toilet because it can cause bowel obstruction. What do we need to know about safety when doing enemas? Angle towards umbilicus. Use room temperature enema. Don't hang too high or it may cause cramping. Use caution with repeat enemas. And if tap water enema, don't repeat. What are the symptoms of fecal impaction? No stool for 3 to 4 days, followed by liquid stool leakage, loss of appetite, distension, cramping, rectal pain, diagnosed by symptoms on digital exam. Can you delegate digital removal of stool? Nope. What do we got to do before doing fecal impaction? Get vitals, data last stool, oxygen, left lateral sims, water soluble lubricant on gloves, ask patient to take slow deep breaths while you insert your finger past the anal sphincter. What's the risk that could happen with fecal impaction? Vagal nerve, which decreases heart rate, and if this occurs, stop procedure. Alright. It's a stoma. Artificial opening in the abdominal wall should be bright red or bright pink and very vascular. What is effluent? Liquid stool. What is an ileostomy? Surgically created artificial opening in ileum. Always has very liquid stool in it. It's earlier in the digestive tract. What is a colostomy? Surgically created artificial opening in the colon. Has more foreign stool in it. That was a loop colostomy. Temporary stoma in the transverse colon. What are some clients that may have a colostomy? Or ileostomy or stoma? Irritable bowel syndrome, cancer, blockage, injury, Bird's effect, severe diverticulitis, and a coma. What is NPO? Nothing to eat or drink or NPO after midnight. What is a clear liquid diet? Popsicles, broth, coffee, clear juices, clear soups. What is included in a full liquid diet? Liquids you can't see through: ice cream, soups, cream of wheat, applesauce. What is a soft diet? Don't require chewing, not spicy, low fiber, and easy on your stomach, nothing hard to digest, but you can have some sweets like cakes or cookies. What's a mechanical soft diet? Only restrictions on the texture, no restriction on the type of food or seasonings on it. What does enteral mean? Goes in via the GI tract. Are nasogastric or orogastric tubes used for long-term use? Nasogastric for long-term use where there's no likely to be Gooch scars, and orogastric is used to vent air in the stomach, more for short-term use. What are 2 reasons for NG tube use? Feeding and decompression. Decompression would be like alcohol overdose and bowel obstruction. What are the nasogastric tube risks? Keep head elevated at 45 degrees to prevent aspiration. Check gastric residual volume and put it back so you don't lose all the electrolytes. What's the biggest risk of NG tubes? Aspiration. How do we make sure that the NG tube is in place? Gold standard is X-ray. If you don't have an X-ray, pH of fluid sucked up via the tubing has got to be less than 5. What are some contraindications for NG tubes? Facial trauma, surgery, esophageal trauma, bleeding because of like unexpected nosebleeds or anticoagulants, 3+ stools in 24 hours, feeding intolerance. You may have to change strength, volume, and concentration. Coughing up sputum, that looks like formula. That may mean that the tube has caused them to aspirate food. All right. Gastric tubes are long-term use and they're like more permanent. They're like peg tubes. All right. Parenteral goes where? Via the bloodstream. Who gets TPN? Patients who cannot eat, will not eat, should not eat, and cannot get enough. When do people get TPN? If they have not eaten for 7 days and we know they can't eat again for a while. All right. Total peripheral nutrition goes via what? Central line. Where does it go? Via superior vena cava into the right atrium. What is the advantage of a TPN? You can use much higher glucose than you can peripherally because of the risk of vasal extravasation. What are we going to do safety-wise when it comes to TPN? Wear a mask while changing a central line dressing and ask patient to wear a mask. This is sterile. What are the risks with TPN? Collapsy, unstable glucose, electrolyte problems, and intolerance. Peripheral parenteral nutrition is via what? Peripheral line, what's the risk? Extravasation. What's a laxative? Laxative. Med that stimulates defecation. Bran and psyllium are examples of what type of laxative? Bulk forming. An example of an irritant or stimulant medication is what? A lubricant to soften the fecal mass. This is a suppository. Med melts when it reaches body temperature, releasing med for absorption. What's an enema? Instilling fluid into the rectum to stimulate defecation or administer a med. It's a cleansing enema. A method of cleansing the bowel before surgery or a diagnostic test. All right, an example of a small volume hypertonic enema example is what? Fleet enema. It's a tap water enema. It's a hypotonic enema. To digitally remove an impaction, use a gloved, heavy, lubricated finger. Example of a diagnostic enema is what? Barium enema. Dehydration may occur when using what? Castor oil. Retention enema is tended to stay in the bowel for a prolonged period of time to soften the fecal mass. What's a cathartic med? It's a med that treats constipation as strong as a laxative. An example of a medicated enema that is not given for the removal of stool is what? K-exolate enema. Common additive to an enema that is an irritant is what? Castile soap. A normal saline enema is safest type of enema to administer. Vagal stimulation may occur during removal of stool digitally. Water toxicity may occur if repeating a tap water enema. An example of a pneumonic enema is saline enema. Mineral oil example, what type of enema? Fleet enema. What does a nephrologist do? Treats and manages dialysis. What does a urologist do? Does a surgery. What is cystitis? Infection of the bladder. What's pyelonephritis? Infection of the kidney. What is hydronephrosis? Urine can't escape the kidneys, causes renal damage long term. What is a suprapubic catheter? Goes in above the pubis symphysis. What is micturition? Urination. What is oliguria? Little urine. What is anuria? Failure of kidneys to produce urine. It's crazy. All right, let's talk about types of incontinence. What causes transient incontinence? Treatable and reversible medical conditions. What are the characteristics of transient incontinence? Delirium, confusion, inflammation, fecal impaction, depression, acute urinary retention, mobility impairment. What are the interventions going to be for transient incontinence? Look for reversible causes with new onset. Notify a healthcare provider of reversible causes. What is the cause of functional incontinence? It's caused outside the urinary tract. Functional deficits such as altered mobility and dexterity, cognitive impairment, poor motivation, or environmental barriers. Okay. So functional is all about like the environment and stuff. It happens outside of the urine. Okay. What's the cause of chronic retention or overflow? Distended bladder, often related to bladder obstruction or poor bladder emptying because of weak/absence bladder contractions. So it'll be like distended bladder and palpation, high post-void residual frequency, involuntary leakage. We know stress incontinence. Overflow is like too much. Bladder's too distended. Stress incontinence is like abdominal pressure wise. So like laughing and stuff. And then urge incontinence, you just can't stop yourself. You gotta go. You gotta go. And reflex incontinence is between C1 and S2. You can read those if you want. Alright, on a urinalysis, what's the normal pH? 4.6 to 8. What's the normal value of protein in urinalysis? Up to 8 milligrams per 100 mils. What's the normal value of glucose in urinalysis? Not normally present. What's the normal value of ketones in urinalysis? Not normally present. Should there be blood in urinalysis? No. What's the normal value of the specific gravity of urinalysis? 1.0053 to 1.030. What are the normal values of RBCs in urinalysis? Up to 2. What are the normal values of white blood cells in urinalysis? 0 to 4. What are the normal values of bacteria in urinalysis? Not normally present. What are the normal values of CAS in the urinalysis? Not really there. What are the normal values of crystals in urinalysis? Not normally present. Alright, what is a random collection method? Can be obtained anytime. Ideal is first in the morning. May test urine with reagent strips. What is clean voided or midstream collection method? Looking to see if there is any bacteria in the urine. Clean with special wipe. Start urinating, and then midstream catch the urine without additional bacteria. What is sterile collection method? Getting it from the urinary catheter. What is a 24-hour collection method? Start and end with void. The first specimen collection is discarded, and then the clock starts. All urine must be kept cold and stored on ice. What is a time collection method? Collection and testing at a specific time of day or over a specific period, measuring hormones, creatine clearance, protein, adrenocortical, special container stays in patient's room on ice. Urine bag goes on a baby under a diaper and to catch urine. What is culture and sensitivity? Sent off when infection is suspected, looks at for bacteria and what kind it is and what drugs to treat it. Just to 48 hours, will often start a broad spectrum antibiotic while waiting for culture and sensitivity and switch to more specific. Tell me about normal urine characteristics. Clear, yellow, or straw colored with pH of 4.6 to 8. No cast, no renal stones. No ketones or glucose. Bacteria does not always mean there's a UTI. Who is at risk for UTIs? Elderly, children, babies, pregnant, bed rest, immobile, neurologic impairment, cognitive impairment, BPH, stuff like that. How do we promote incontinence? Ambulation, privacy, assisting to standing posture, elevate head of bed, warm H2O over perineal area, run H2O in the bathroom, offer parting liquid, assist to comfortable position. What are some UTI reduction measures? Shower instead of bathing, hydrate, hygiene, don't douche, avoid after intimacy, wear cotton clothing, no tight fitting clothes, wipe front to back. What's a condom cath? Empty urine and send to collection bag on leg. What's a straight cath? Straight, thin tube, usually used once and thrown away. What is a caudate cath? Specifically designed to maneuver around obstructions in the urethra, slightly bent at tip. What's a Foley cath? Most common type of indwelling urinary catheter. What is a suprapubic cath? Drains urine via small hole in belly. What's a nephrostomy? Opening allowing thin tube to enter the kidney. All right. When would we use catheters? Use when appropriate and remove ASAP. Avoid use for incontinence. And patients use as needed rather than routinely. For operative patients, remove full ASAP unless required. So use it for like acute urinary retention or bladder output obstruction. Need for accurate measurement of bowel urination. So pre-op, so clients undergoing urologic surgery or other surgery. Anticipated prolonged duration of surgery. Getting diuretics or large volume infusions. Intraoperative morning. Healing of sacral or perineal wound. Okay. What are the signs and symptoms of UTI? Fever, dysuria, pelvic pain, urgency, tenderness, confusion, frequency, burning, cloudy urine, odor, and blood. How can we prevent CAUTIs? Use evidence-based bundle of supplies for one-time use. Insert with aseptic technique and sterile equipment. Secure catheter to prevent movement and pulling it out. Maintain closed urinary drainage system. Maintain unobstructed flow via catheter, drainage, tubing, and bag. Keep drainage bag below level bladder. Avoid dependent loops and tubing. Prevent bag from touching floor. When emptying, use separate drainage receptacle for each patient. Don't let drainage spigot touch the receptacle. Before transfers or activity, drain all urine in empty bag. Empty bag when half full. Perform routine perineal care daily and wipe. And after soiling, use antiseptic wipes. Be sure to use a wipe to clean the length of the exposed catheter. Obtain urine samples using the sampling port. Cleanse and use sterile syringe. Quality improvement program should be in place that alert providers that a catheter is in place. What are the two most important questions about a catheter? When was the catheter removed and has the client voided? So, your textbook does not emphasize the risk for urinary retention after Foley is removed, but this is important. Assess to determine if the client has voided by 4 hours after the Foley is removed. Small amount of urine is not adequate. If no output or small volume of output, start encouraging fluids. Turn on sink the bathroom to encourage fluids. 4 to 6 hours. Try more exercise to promote voiding in 6 to 8 hours. Or if there's pain, discomfort, extension, call a healthcare provider to obtain a straight cath. What's the minimum urine output? 30 mils an hour. Report of this is less than this for 2 consecutive hours, so 720 mils a day is minimal. All right, what can the NAP do? Collect urine specimens, do urine chemical screening, test for occult blood, emesis testing, sputum specimen, blood specimens by venipuncture, blood glucose, cath care and removing cath, bladder scan, and applying random cath. What can the NAP not do? Collect nose, throat culture, vaginal discharge specimens, suction sputum specimens, wound drain specimens, ABG, put in a cath, irrigate a cath, perform continuous bladder irrigation, digital stool remover. All right, what is preload? Volume. What is afterload? Pressure. All right. What's the blood flow through the heart? Superior inferior vena cava, enter into right atrium, tricuspid valve, to right ventricle, to pulmonary valve, to pulmonary artery, to lungs, to pulmonary vein, to left atrium, to mitral, to tricuspid valve, to left ventricle, to aortic valve, to aorta. All right. What is perfusion? Blood flow to cells, delivering oxygen, removing waste products. What is the formula for MAP? 2 diastolic plus systolic divided by 3. Alright, SA to AV to bundle of His to per country fibers. Central is cardiac output, local, okay. What does cardiac output mean? Blood ejected from left ventricle each minute. What is stroke volume? Volume of blood ejected during systole. What is the formula for cardiac output? Heart rate times stroke volume. What is the normal map? 70 to 100 or greater than 60.5. Alright. Cardiac perfusion, heart needs to perfuse itself first. Pulmonary perfusion, very high pressures in pulmonary artery, backup of blood. Heart failure, cerebral perfusion, 3 to 8 minutes. So what things increase preload? Hypervolemia, regurgitation of cardiac valves, and heart failure. Alright, what things increase afterload? Hypertension, vasoconstriction. So if you increase afterload, increase cardiac workload. So preload means volume of blood in left ventricle at end of diastole, and afterload means resistance left ventricle must overcome. Okay. Alright, what are you going to do? What meds are we going to give for preload? Diuretics. What meds are we going to give for afterload? Vasodilators. What is shock? Not getting enough blood flow, not enough oxygen, so organs will be damaged and potentially die. What are symptoms of shock? Altered consciousness, restlessness, irritability, rapid breathing, pale/blue/cool/moist skin, nausea, vomiting, excessive thirst, rapid and weak pulse. Hypovolemia to low venous return, to low preload, to low cardiac output, to hypertension, to perfusion failure, and hypoxia, and organ failure. What is the value of BNP? Less than 100. When will it go up? Heart failure. What is sepsis? Blood infection leads to organ failure. Bacteria enters blood. Vasodilation occurs, and fluid leaks in surrounding tissues. Decreased blood flow to organs leads to failure. All right. What is anaerobic metabolism? Body's attempt at an energy source in the absence of oxygen. This occurs when your lungs can't pull enough oxygen in the bloodstream to keep up with the demands of your muscles for energy. Waste builds up. Lactic acid builds up. This is used to determine sepsis. Then rhabdomyolysis, what that is. Chest pain, blood flow decrease, heart failure, edema, cause lots of pain, dizziness, and SNS. What are the assessments we'll do for central perfusion? Heart rate, blood pressure, labs, and urinary output. What assessments are we going to do for cerebral perfusion? Orientation, LOC, bilateral movement, sensation, speech, and carotid pulses. What assessments are we going to do for peripheral tissue perfusion? Skin warm, appropriate color, dry, pulses pregnant, rate and rhythm, capillary refill less than 2. What is troponin present in MI? If we have high ANP and BNP, heart failure. Hemocysteine is predictor of CAD. CRP goes up when inflammatory processes are going on. Lipids for plaque. Okay. PQRST. P wave, SA nude fires and depolarizes. So P wave is atria depolarization. QRS is atria repolarization. Ventricle depolarization. T wave is ventricular repolarization. It must have a P wave to a normal sinus rhythm. Sinus tachycardia, bradycardia is. Asystole is flatline, no electrical activity, unshockable. V-tac, ventricular squeezing way too fast, may not have a pulse but still shockable. V-fib, electrical firing in different areas of the ventricle, undulating and uncontrolled, so you don't have a pulse, still shockable. A-fib, firing from all over, so you don't have an atrial kick, not a lethal rhythm, but ventricles are still working, and you still have a pulse. Oh.